My name's PJ. I'm one of the residents at Nepean Hospital. I've just been asked to put together a bit of a lecture for you guys on reading ECGs. So, I think at this stage it's pretty safe to say that people understand that there's more than one way to interpret or read an ECG. I'm going to be putting forward an example of a format that I use while on the wards. You can use this one if you'd like, but I totally get and understand that if there's another example that you may use, if you prefer an alternative method, then this lecture can at least be used to help with reviewing the physiology behind all the waves and all the lines going on in an ECG. I think it goes without saying that the best way to practice getting better at reading ECGs is to actually go out and read ECGs. In saying that, though, I don't want this lecture to turn into another lecture where you just get an example of an ECG and get someone to interpret it before moving on to the next one. Obviously, that can't really happen with this kind of lecture being recorded. So we will go through the breakdown of the components of each of the parts of the ECG and brush up on your physiology. We'll have a look at the approach or technique that I mentioned to reading ECGs. I think it's incredibly important to have a system to follow. With whichever one you choose, I'm going to stick with that technique so you can be systematic in your approach. This will help to make sure you don't miss any critical steps. It will also help to make it easier for you when you get an ECG shoved in your face while on rounds with the consultants. You get asked to interpret it. You may not be able to explain exactly what the pathology is that you see happening at that time, but at least you'll be able to read an ECG and recognize what is abnormal from a normal ECG, and then this allows you to at least triage and escalate to any senior staff if you do need any help, or at least be able to explain what is normal or abnormal about an ECG when the consultant asks you. So let's jump into the basics as to what an ECG actually is. So when we say ECG, generally around the hospital, generally what we mean is a 12-lead ECG. There's other different forms of ECGs. You can get a 3-lead, 4-lead. It all usually depends on where you're actually getting the ECG done, whether it's in a hospital, out in the community, in an ambulance, etc. So for ease of communication, we'll assume that we're always considering a 12-lead ECG. So what's in a 12-lead ECG? You actually have 10 electrodes, 4 limb electrodes, and 6 precordium electrodes. So we see the V1 to V6, as well as left arm, right arm, left leg, right leg. And through some physics learning, that's a bit above me, but basically you get 12 different vectors or leads from these 10 electrodes that then become the 12 leads that we know. Each of these leads or vectors represents a measurement of the electrical activity that is working through the heart in that area. It is a wave function of that charge. So if you look at the figure in the bottom right, you can see the circle with all the leads labeled around it. You have AVL, lead 1, lead 2, etc. The point on the circle where the lead name is, that is the positive end of that lead or the positive end of the vector. So if there is an increase in electrical activity in that direction, i.e. along that lead, then you will see an increase in the positive value or the line on the ECG. So I just want to take this example of lead 2. So as we saw from the previous slide, in lead 2 is at a positive, or is at a position of 60 degrees of axis. So we see the positive electrode down at the side of the apex of the heart, and the negative up near the opposite, near the aorta and SVC. Lead 2 is usually always the example lead on an ECG or used as the rhythm strip, as that is kind of the normal sort of heart direction, and that way sort of we get that classic PQRS picture that we see here. That everyone kind of knows. Lead 2's vector follows the same direction of the heart's wiring system, so that lead 2 is kind of in this direction, and we can see just from the shape of the heart that as the charge goes down and then flows out, that's kind of in a directly sort of perpendicular direction to what the lead would be. So we usually try and think of the heart as 360 degrees, as you see with the whole sort of all the leads that we have, and you have 0 degrees at the top, 180 at the bottom, but as we know it's slightly rotated, so the real positive or negative vectors is going to be through that 60 degrees there, which is lead 2. But the main thing that I want you to get from this slide is correlating that when electrical activity travels down the heart, you can first see that impact what is seen on each of the leads wave functions. So you can see how it impacts on the leads wave functions. So for lead 2, as the charge travels down from the negative portion down the atria towards the AV node, we can see that correlates with the little bit here, which is the P wave, as it's going towards the positive end, and so you get that positive change. As we go down a little bit further, we start to get that interventricular sort of septum getting innervated, so that's that little bit of a Q wave. And then as it travels down the septum, and it's going further and further down the septum here, we can see that you get more of that positive waves as it comes towards the positive value. As it then goes back up away from the positive value through the Purkinje fibers, we see it starts coming back down through number 4 there. And then as it keeps going up even further, you can see that once again there. Then it goes through ventricular repolarization, which is something we'll touch on later. But basically, I just wanted you to kind of see the concept of as the electricity travels towards that positive end of the lead, that's when you see that positive upstroke in the QRS, or sorry, in the ECG. This is the example of the printout we all know. It has each of the 12 leads with the waveforms for each of those leads. So at a single snapshot in time, we can have an idea of the electrical activity in the heart because we have this picture of all the different vectors and how much positive or how much electrical activity is each of those leads or vectors. You'll notice that each of the leads is boxed off and has a label on them of lateral, inferior, septal, or anterior. These labels correlate with the area or blood supply of the heart that one would expect to be affected or causing any pathology that you may see. So if we saw ischemic changes on ECG, we could summarize that there's potentially an infarction occurring somewhere. But by correlating that with the leads that we see those ischemic changes in, we can then figure out which artery or blood supply is compromised. So for example, if we saw ST depression in leads 2, 3, and AVF, we could then say that there's an inferior infarction occurring, as it is the affected leads that correlate with the inferior circulation of the heart. This will make a little bit more sense when we go through breaking down the components of the actual waveform as seen on ECG. So, to start things off, the first wave we see on a normal ECG strip is going to be the P wave. That's the small little blip seen right before the big QRS value usually. We can see it here in the blue portion of the figure there. This represents the atrial depolarization. Generally, the duration should be less than 0.12 seconds or less than 120 milliseconds, or also known as 3 small squares. Next is the Q wave. This is any negative deflection prior to the R wave. This represents the normal left to right depolarization of the interventricular septum. So imagine as the charge is traveling through the atria from the SA to the AV node. As it hits the AV node, there's going to be some charge that is spreading out through the interventricular septum. It may only be small, but it is there, and the ECG can pick it up. And this is what we see as the Q wave right down there. So do note that small septal Q waves are typically seen in the left-sided leads, so that's 1, AVL, V5, and V6. They do have variants, and they can sometimes be pathological, which we'll go over in just a second. But generally, as I said, these septal Q waves are on the left-sided leads, and the 1, AVL, or V5, or V6. The Q wave variants, as we said, small can be normal in most leads. However, there are pathological Q waves, and so the criteria is listed there as greater than 40 milliseconds wide, greater than 2 mils deep, greater than 25% of the QRX complex, or if they're seen on those right-sided precordial leads, V1 to V3. When you point to when you see pathological Q waves, it can point to a current infarction occurring or potentially a prior infarction. Regardless, they would require further investigation. This could be just potentially comparing it with an old ECG, which I will go on to say is something incredibly important to have. You almost always need to have a previous ECG to sort of accurately critique a new ECG, as you don't know whether any of the changes will be old or new changes, and if they're old changes, they may not need to be sort of addressed as quickly, but obviously if they're new changes, they do need to be addressed. And something to keep in mind is that in lead 3 and AVR, it can be normal to have deeper Q waves, but if they're seen in those right-sided leads, that's when they're likely going to be pathological. Next up is the R wave. So we'll look at the R tracing right here. This represents the depolarization of the ventricles and is that next upward deflection after the P wave. So we have the P, Q, and then that big upward is the R wave. We usually see it as a big upstroke, and that makes sense when we consider that this is the electrical activity that is causing the ventricles to contract. They are the biggest part of the heart, and therefore, as expected, they create the highest charge going through them, and then we see that as that big upstroke of the R value. If we consider back to the previous slides, looking at the charge traveling down the heart and how it correlates with the ECG when it's positive, so just going back to this one here, how we see that as it goes down, it's going towards the positive aspect of the heart. If the R wave is traveling down towards the interventricular septum, then when it reaches the Purkinje fibers, which is what the S wave represents, is the depolarization of that Purkinje fibers, it starts to go in the opposite direction. So it's coming down the septum, and then as it goes back, so coming down the septum, and then as it goes back up the other way, it's obviously turning around and going in the complete opposite direction, which is why we expect the S wave to be in that opposite direction, and that's sort of the negative deflection of the ECG trace. We'll just leave that there for a second. We'll come back to S wave and R waves a little bit later on. But the next thing to consider is the T wave. So this is the positive deflection after each QRS complex. It represents ventricular repolarization. It's also important to consider that T waves can be negative if the R wave is negative. Another criteria to consider is that T wave inversion in leads other than V1 or AVR can be normal. So if you see it in V1 or AVR, it's something to consider as pathological, but in the other ways, it can be normal. As well, a normal amplitude, which comes into sort of consideration when we look at ischemia, which we'll touch on a later time. Less than 5 mils in the limb leads and less than 10 mils in the precordial leads is going to be deemed sort of non-pathological. The last wave of the set here is called the U wave. This is a bit of an interesting one. It's probably not super useful at this stage of our careers, but right now it's good to know about how to be able to differentiate from potentially abnormal pathology. It also looks pretty good if you can point it out to the consultant when they do ask you about what that random extra wave is, and be able to sort of comment that the U wave is a small deflection immediately following the T wave. It's usually seen in the same direction as that T wave and can best be seen in those leads V2 and V3. When the consultant then goes on to ask you, well, what causes the U wave, you can show them your superior intellect by letting them know that, in fact, the cause of the U wave is unknown. We do have some potential theories, as sort of stated right there, with the delayed repolarization, prolonged repolarization of M cells, or after potentials resulting from mechanical forces and then ventricular wall. I think it's just important to make note that these do exist and to be able to describe them a little bit, but I wouldn't worry too much about the specifics of the U wave. All right. Now that we have an understanding behind the basics of what an ECG is actually looking at, of course, there's a little bit more to it than just knowing what a P wave is. We need to be able to sort of put it all together and get an understanding of what it means for the patient when you're actually reading their ECGs. As I previously mentioned, there's many different ways or systems to interpret ECGs. This is the one I try and use. If you don't like it, that's fine. You won't hurt my feelings. But hopefully at least the first bit of the lecture can assist you in using or working on whatever method you use for interpreting ECGs. And also maybe even having a look at it this way to help see whether it can give you a different perspective or different techniques that you can add to your interpretation method. What I want to focus on is being able to interpret what is normal and how to find things like the rate, the rhythm, and any axis deviation. I want you to be able to identify when those things are present. This is not going to be a very encompassing lecture that explains what causes the changes in rate, rhythm, or axis deviation, as there's so many different things that can cause any pathology or changes from the normal. It just won't fit in this kind of lecture. Instead, this will help you to work on these techniques to recognize those changes so that when you do go out and practice reading ECGs on your own time, as I know everyone's going to do on these quarantine Saturday nights, then you can determine what those changes are, and then from real life sort of practice of reading the ECGs, you can see the changes and then determine what pathology is specific for each of the ECGs you're looking at. All right, so let's just jump in. As you can see listed there in the order, this is the way that I try and interpret ECGs. You look through each of these characteristics for each of the leads on that 12-lead printout, and this then provides a systematic approach, ensuring you don't miss anything and helps to guide your interpretation when things may not be 100% clear or obvious. So you start off by looking at the rate, go down to the rhythm, determine any axis deviation that may occur, looking at the intervals and any conduction abnormalities, hypertrophy, any chamber enlargements, and finally looking at ischemic or infarction changes. Just wanted to throw this slide up here to remind ourselves of what 1 square or 1 millimeter really correlates to. I find that these terms of kind of 1 square or 1 mil get thrown around so often, and sometimes we forget what it actually truly relates to. So this is just a little visual representation reminding ourselves what 1 square means. So 1 tiny square, sorry about that, 1 tiny square there, and then 1 big square, and what it relates to in terms of time, and then also distance on the ECG. All right, so first thing we look at is rate. A normal rate is considered 60 to 100 beats per minute, and how we determine rate is going to be dependent on whether it's a regular or irregular rhythm. So for a regular rate, when the rhythm is regular, the best way to do it is going to be by taking 300 and dividing that number by the number of large squares in between the R waves. So if we look here as an example, say this was an ECG for an individual, and so looking at the pink section here, if there was one square between each of the R intervals for the whole sort of ECG strip, you could determine that the rate would be about 300 beats per minute. That's obviously extremely fast and very worrisome. Because you have one square, 300 divided by 1 is 300. Going on to the next one, the blue here, if there was two squares between all the different R values, you could determine that the rate was 150 beats per minute, as 300 divided by 2 is 150. So along in the teal, moving down, if there's three squares between all the R intervals, 300 divided by 3 is 100, and you get it for the next few. If there's 4, it'd be 75, 5, 6. Basically, it's kind of a rudimentary, easy way to kind of have a look at things, but it only really does work if it is a regular rhythm. If it's an irregular rhythm, the best way to do that is to look at the rhythm strip at the bottom, which is usually lead 2. It's a 10-second printout. So if we have a 10-second printout, what we can do when the rate is irregular, we can count all the different R waves that are in that 10-second strip. If we then take that number and multiply it by 6, that will give us an indication as to how many beats per minute there would be in 60 seconds. 10 times 6 is 60. So if we look at this one, we can see that there's 19 R waves in this 10-second period. And so if you multiply that by 6, that would determine the rate to be about 114 beats per minute. Moving on. Next technique to look at is looking at the rhythm of an ECG strip to look at whether it's regular or irregular. We probably have an idea beforehand as whether or not it's regular or irregular, determined on how we've determined what the rate to be. But it is important to quantify that just a little bit more. So if it's regular, that's great. We know that the RR intervals are the same across the whole tracing. If it's irregular and the RR interval is changing across the strip, then we need to determine if it's regularly or irregularly irregular. As if it's regularly irregular, you can see sort of a regular pattern of repeating varying RR intervals, so same kind of pattern, and they have sort of that same pattern repeating, but the RR intervals change. So this is seen commonly as something like atrial flutter. Or if it's just completely irregular and there's no rhyme or reason between how the RR intervals are spaced, that would be irregularly irregular, and you can see that through AFib and VFib. So one method that I like to take as an example is if we had this rhythm strip here, say it was going a little bit faster, it'd be hard to really sort of see whether there was the same distance between, say, this RR interval and this RR interval. So sometimes if it's a little bit more complicated, what you can do is you can take a sheet of paper and line it up so it's all lined up, kind of this edge is here. So all you have is just the little blips of the R waves kind of pointing up above the edge of that strip of paper. So if it's right along here, you can then sort of line it up and you see these little blips of where the R's wave would be. You make a quick notch with a pen or a pencil or something on the other piece of paper, and so you have that determined distance between the RR intervals. That way, to determine whether there's the same distance between the other R intervals down the rhythm strip, all you have to do is, if you have those ticks there and there on the sheet of paper, you just slide it down to the next one. So the tick that was here, you put onto this R wave here, and the tick that was on this R wave then gets pushed down further. And so if the two ticks line up already perfectly onto these two R waves, you can imagine that it's a regular interval as it's the same RR interval between it. So then you just keep shuffling it down the line. So this one, you'd probably notice that, okay, that second tick is a little bit past this R wave because this is a smaller gap than this is. And so that kind of points to the evidence that it's irregular. Best way, once again, is to look at it is by finding some ECGs, getting out the rhythm strip and looking to see whether you can tell whether it's regular or irregular. For the most part, you can determine sort of just by looking at it with the rate, but it is important to sort of describe the irregularity a little bit more. All right, axis. This can be a little bit complicated, but I assure you that once it kind of all falls into place and makes sense, it can be quite easy to understand. Basically, the best way to describe axis is the mean vector of the electrical activity of the heart. So this is if all the vectors were added up together from all of the different leads and then averaged out, this is what the direction would be for that average of all the electrical activity in the heart. It's kind of like the average electrical activity and what direction it's pointing in. So I've written the values there as what normal, left and right axis deviation. You can see -30 to 90, less than 30 or less than negative 30 for left or greater than 90 for right. The best way I find to sort of understand this is to see it visually though, however. So this represents what kind of axis deviation would exist, if any, based off the directions of the axis or whatever the mean vector is pointing to. So this is a visual representation of how the axes relate to the picture of the heart. If we remember back to the start of the lecture, we talked about how the heart doesn't line up perfectly up and down from negative 90 to positive 90. It's slightly rotated in line with that lead 2, which is where the apex is located down here. So the heart doesn't go straight up and down like that. It's more of kind of like this, which is why lead 2 points down to kind of 60 degrees, as that's in line with the apex. But this is then why we see a normal axis to be between negative 30 and 90, as long as the heart, the average electrical activity is traveling in this direction from here down to here, we can see that it's going to be traveling down the standard kind of interventricular conduction system, and that's in the normal direction. So that's what we would normally want things to go, but obviously nothing's normal in medicine and things change. So how do we determine if that axis is deviated or things aren't normal? So there's obviously many different ways that you can determine it. This is the method that I like to use, and I think it's a pretty good representation of things to sort of use to determine the axis deviation. So remember that in any lead, it has a positive and negative direction. It's simply a vector showing positive or negative charge based off the electrical activity of the heart. So if we focus on just a few leads that work in right angles to each other, we can determine the average electrical activity of the whole heart and then the axis of the heart. So consider these three ECG tracings to be snapshots from the same ECG. So we can see in lead 1 that the R value is positive. It's pointing upwards, and that points to it being positive. If we then look at the circle underneath, we know that the direction of lead 1 is positive to the right, specifically to 0 degrees right there. So if the QRS is positive in lead 1, as we see as it's pointing up, we know that the electrical activity in lead 1 is going to be pointing in that direction, to the right, so that we know, we can't exactly say exactly which direction, whether it's that way, that way, that way, that way, that way, or that way, but because it's positive, we know it's at least going to be going in that direction. So we can take half of the circle and highlight the positive half in light blue here, and just remember that for now. Now, the axis is the average of the sum of all the vectors, so we need to consider more than just one lead. Remembering the direction we saw in lead 1, let us now consider lead 2. It's positive in the plus 60 degrees direction and negative in the minus 120 degrees direction. For our example on the ECG, we have it that the R wave is negative. It's going down there. So that means the electrical activity is traveling towards the negative half. So it's up towards the yellow half of the circle, up towards negative 120 here. Lead 2, negative R value there, going to be towards lead 2, which is the negative side of it. So for our example, we have the negative, as we said. So if we take that negative half of the circle, because we don't know exactly which direction it's going, we just know it's on average going in the negative direction, we take that yellow half and remember that yellow half again. So we have lead 1 and lead 2. Let's now consider AVF. AVF is positive towards 90 degrees, sort of in the bottom here, and then negative towards negative 90. It's that perfect up and down lead representing the heart. And looking at our ECG tracing, we can see that the R wave is negative once again. So the electrical activity in this lead is traveling towards the top half, or that red portion. So if we look at all the half circles that we've used, the blue, the yellow, and the red, and lay them onto the same circle as we have here, the only place that we can see all of the halves line up in a common area where all three are present is in this little wedge right here. So by determining that a positive in lead 1, negative in lead 2, and negative in AVF, that points that the only way these all line up together in the same spot is in this little branch here from negative 90 to negative 30, which correlates with left axis deviation, which is pathological and something that needs to be considered. This can be a bit tricky sometimes, and I assure you once you get it, you'll get it. But just remember to look at the negative or positive values for lead 1, lead 2, and AVF. Add those all together and find that quadrant where they all line up based off the half wedges of their circle, and then that will give you your average electrical activity. And then from that, if there is any axis deviation or what direction that deviation is in. Next up, we have looking at the intervals and then later on the conduction of the electrical activity in the heart. So the first thing to look for is assessing for normal PR, QRS, and QT intervals. So normal PR intervals less than 0.2 seconds, or 120 to 200 milliseconds, or 3 to 5 small squares. QRS is less than 0.12, or 120 milliseconds, or less than 3 small squares. QT. So the printouts that you get for the 12-lead ECGs will give you usually a specific value for each of the PR, QRS, or QT. They'll also give you a QTC, which is basically a corrected QT value, basically giving you a QT value if the heart rate was 60 beats per minute. Obviously, not everyone has a heart rate of 60 beats per minute. So what it tries to do is it gives you that sort of correlated value at 60 beats per minute, because as the heart is beating faster, there's less time for it to repolarize, and that can change the QT interval. So QTC is kind of the average of what would be expected in a normal sort of conditions. And therefore, if this QTC is prolonged, so greater than 440 in men or 460 in women, that can be pathological. If it is up over 500, that's at an increased risk of torsades de pointe, which can be very, very deadly. And it can be seen as abnormally short if it's less than 350. A quick useful rule of thumb, if you don't have a specific number or a specific value for QTC, is that if you look at the normal QT, if you look at a QT, you can determine it to likely be normal if it's less than half the preceding RR value. So if you look at this RR interval here, you can see that this QT interval is less than half of that. And you can kind of see it too on here as well, but it's best to do it with the preceding RR interval. But if you look here at Q to T, that is definitely less than half of the RR interval. And just as we said before, they'll give you the exact printouts, the exact sort of millisecond values, but you can just have a look here and count them yourself if you need to. You got the PR interval there, which is written through there, then the QRS, and then the QT. So it's all written out there for you, and you'll get the exact values. Next, looking at the conduction of the electrical activity down the heart, looking for any blockages or any bundle branch block. These are the characteristics of left and right bundle branch block are listed below. So if you see any of the criteria, it can point to there being sort of a bundle branch block depending on which finding you see. So greater than 120 milliseconds for QRS, or if you have a broad notched R waves in lead V4 and V5. So we see that notched right there. And sometimes you can see it in one in AVL, and another sign of left bundle branch block is that deep broad S wave in V1 and V2. For right bundle branch block, criteria that you'll see are a QRS duration of greater than 120. You can have a positive QRS in lead V1 with that RSR prime. So that's that little notch up there, and then S wave down, and then that bigger notched R wave in V1 there, that's pointing towards right bundle branch block. And then also that broader S wave in leads V5 or 6, which is greater than 140. I also have written down here as well just the idea of a left anterior or left posterior fascicular block or a bifascicular block. That relates to kind of a further breakdown of left bundle branch block. I wouldn't worry about it too much right now, but just know that that is possible to have that differentiation, but it's just kind of a further breakdown of left bundle branch block. It's just a little bit more specific where the actual blockage is. Sometimes you'll hear people, when it comes to bundle branch block, they talk about sort of William or MORROW when looking for signs of left or right bundle branch block. This is just a technique that you can use to try and remind yourself what you're actually looking for. So with William, this relates to left bundle branch block. William has 2 L's in the middle to help you kind of remind whether it's for left or right that you're looking at. So William was for left. You notice that William starts with a W and ends with an M. So the start of the name correlates with V1, and the last letter of the name correlates with V5 or 6. So you can use this as a quick tool to remind yourself of what you're looking for with left bundle branch block in an ECG strip. So with William, there's 2 L's for left. For V1, you look to see a W. So you see down here, there's that tiny little notched W down there. That's related to V1. And then if you look over to V5 or V6, you can see this notch here that looks like an M. So William for left bundle branch block. The next you can have another thing you can look to remind yourself with right bundle branch block is something called MORROW. So MORROW has 2 R's in the middle. It's reminding you that you're looking at right bundle branch block, and it's the opposite to William in that the M correlates more with V1, and then the W is looking at V6. So if we look here, it's a little bit harder to see with right bundle branch block, but you can see this kind of prime notch sort of value that you have here. If you kind of expanded it out a little bit, you can see that it's a bit of an M, like that. Bit harder to see, but it is there. And then here, it kind of looks like a normal QRS, but if you actually sort of see, you can see that there's a bit of a Q there, up, down, and up, just like a W. A little bit harder, and this isn't sort of kind of the be-all, end-all. You don't have to have these things. It's just something that often sort of presents this way. And if you have these sort of little mnemonics to help you remember, it can just make it a little bit easier for you when you do see those changes that are perhaps indicative. You see those notched sort of V1 and V6 leads. You see some notched R waves there, but you can't remember which one goes with which. Just remember William and MORROW, and that should hopefully try and make it a bit easier for you to remember. Next, we want to look at the hypertrophy of the ventricles, or if there's any chamber enlargement. So there's many different criteria that you can use to try and consider LVH or RVH. The Sokolov-Lyon for LVH is generally the most common one. It's pretty straightforward to determine. All you do is add the depth of the S wave in V1 with the height of the R wave in V5 or V6. And if the sum of that is greater than 35 millimeters, you can then determine that LVH is present. So if we look here, we can see the S wave in V1 is dropping down, and there's over 3 big squares. In the R wave in V5, there's 1, 2, 3, 4, 5, 6. So there's over 9 big squares, which is going to be greater than 35 mils. So you can determine from this ECG that this patient has left ventricular hypertrophy. So there's different criteria for right ventricular hypertrophy as well. So some of the things that you can see is if there's axis deviation of greater than a positive 110 degrees or more, or if there's a dominant R wave in V1 that has a greater than 7 millimeter tall, or as we can see there, or an RS ratio that's greater than 1, or if there's a dominant S wave down here in V5 or V6 that's greater than 7 mils deep, or the opposite of the R to S ratio of less than 1 when looking at V5 or V6. Just an important note to make is this is all assuming that the QRS is a normal duration of less than 120 milliseconds, as you have to make sure that these changes aren't actually due to a right bundle branch block, which would have a longer QRS duration and still have some of these changes, but the pathology is likely not related to hypertrophy of the ventricles, but to the right bundle branch block. And just quickly touching over atrial enlargement, not as important, but something to know that it does exist. So the criteria for left atrial enlargement, you usually see a biphasic P wave with the negative terminal component of the P waves in V1 greater than or equal to 1 mil wide and 1 mil deep. So in V1 we see here we have a slight upstroke there of the P wave, but then this bigger sort of notched negative portion that's that deeper and wider part of the P wave there. You can also see a sort of wider P wave, as we see here in lead 2, that's greater than 100 milliseconds. And when you have this left atrial enlargement, sometimes it can be called P mitrale. For right atrial enlargement, you're basically just looking to see whether the P wave has a greater than 2.5 millimeter height in leads either 2, 3, or AVF. So we have here in lead 2 a much bigger height than 2.5 mils. And that would point to some right atrial enlargement, and that can sometimes be called P mitrale. All right, moving on. The last step that we can look at when interpreting ECGs is going to be looking for any ischemic changes that may be present. This generally comes by looking at the ST segment and determining if there's any depression or elevation that may be present. If there's an injury or infarct and we see ST elevation, we can assume that there is damage in those leads where the ST elevation is facing. It can be considered with ST elevation that the damage that is occurring in the heart is thought to be completely transmural, meaning through the whole thickness of the cardiac muscle and involving the outer epicardium, sorry. If we see ST depression, we can assume that there is damage in the infected leads, but there are thoughts that this damage is subendocardial, meaning it doesn't get through the full thickness. However, I will state that, as my colleagues have very nicely reminded me, that this theory hasn't always held up when examining patients' hearts postmortemly, and that the ST elevation doesn't always mean full thickness, and vice versa. But I do want to put this photo up as it helps to explain the whole idea of in the leads facing the affected areas. It's a nice 3D representation of the heart with the limb and precordial leads placed where they measure electrical activity in the heart. So remember, it is a 3D structure. It's not just a flat sort of plane going in one direction. It's a whole 3D sort of summary of the electrical activity in the heart, and it's really that average between all 12 leads that you really get the best picture. But what I mean, what I'm trying to say by in the leads facing the affected area, it means that, say, for example, we're looking at the right coronary artery. If there's any damage or blockage or ischemia from the right coronary artery, we would expect to see changes in V1s or lead 3, as those are the leads facing directly overlaying the distribution of the right coronary artery. And therefore, any ischemia is going to affect the electrical signals traveling through the heart in that area, and the electrical signals are being picked up by those leads, i.e. V1 or lead 3, and then we'll see the changes there. So you see the right coronary artery coming down here. You got lead 3 coming out right there, and then V1 coming right out there. So that's really going to be the area that's going to show you where that electrical activity is coming out. So I just wanted to have that kind of visual 3D representation for you there. And then quickly go through kind of the sequence of the ischemic changes that occur when someone is having a myocardial infarction. So we can see the visualization of the changes up in the top right row there as we go through the ST changes and then the Q waves that may occur. I just wanted to touch on this stuff so that when you're looking in ECG, you can see where these changes and help to point out, along with the detailed history, of course, if it's any new or any old ischemia that may be true. So generally, as ischemia sort of progresses through the heart, it starts off by showing signs on ECG, and the first sort of ECG changes that you'll see will be hyperacute T waves. So these are your tall, very symmetric T waves, and these are once again in the leads facing the infected area, or infarcted area, sorry, as I mentioned that last slide. And these can be present with or without ST elevation. As the infarction progresses without any sort of meaningful intervention, what you would expect to see is some progression of some ST elevation. Once again, in the leads facing that infarcted area, it can then sometimes present as depression and then elevation. And this usually is happening in the first hours post-infarct. Just a quick thing to consider is that in an acute posterior MI, there's ST depression in V1s to V3. And you may see it as depression in these leads, ST depression in these leads looking towards an end STEMI, when in fact these are reciprocal changes to ST elevation in the posterior leads. However, these are not recorded on your standard 12-lead ECG. You actually need to get a 15-lead ECG. As I said, there's many different ECGs, but if you do see that ST depression in V1s to V3, there is potentially the fact that it's actually posterior ST elevation, and this depression isn't sort of the driving infarct, but reciprocal to that ST elevation in the posterior leads. After that ST changes, you can get some significant Q waves. So these are the ones that we said were greater than 40 milliseconds or greater than 1/3 of the total QRS. And these need to be present in at least 2 consecutive leads in the same territory. They can start to show up sort of hours or days post-infarct. And they can also be related with or without the ST changes or other sort of signs of infarction. And then after all of this, sort of days or weeks later on after the infarction, you'll start to see that inverted T waves afterwards. And then here is just an example of a pathological Q wave. As it gets older, you get these deep Q waves, and those are pathological. I think that's all I kind of have for me. I've just written on there practice, 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 because the best sort of thing for getting better at ECGs is always going to be just going out there and practicing sort of real life questions from real life patients. I put my email there. If you have any questions, feel free to fire me a message. hopefully this was helpful. I appreciate that it's obviously a bit difficult when it's sort of just a delivered lecture and you can't sort of ask questions or any feedback at all, and especially with something like ECGs where you just need to have that practice and feedback. This is kind of just a lecture to be able to sort of give you a backing or a basis in the sort of rudimentary and basics physiology and understanding of it, and then sort of use it as up to you guys to then go on and do your own practice. Hopefully it was helpful. Once again, PJ is my name. If you got any questions, please send those through to that email there. And otherwise, all the best of luck to you. If you see me on the wards, feel free to say hello. Thanks.